So I had a situation when I was out on a wild, windy island. In fact, it was an island chain. And I was speaking to the parents of a child who was about 40 minutes drive away. The child was ex-prem, at risk of respiratory problems. And, I just didn't have all the information I needed on the phone. My husband had an episode of burnout 6 years ago. He's a hospital consultant. So he'd spend all day seeing patients at one hospital, and then he'd spend all evening driving around one of the about 8 other hospitals he was looking after, and it almost killed him.
My guest today is Dr. Rebecca Payne. She is an NIHR fellow at the Oxford University. She's also a portfolio GP with special interest in video consultation. Hi Rebecca, how are you doing?
Hi, good. Glad to join you from Orkney today.
Thank you for joining us today. So could you introduce yourself for people who might not know you?
Yeah, I am the luckiest GP in the world, and I have the second coolest job in the world after Kate Closer, who's a GP on the Antarctic survey for Australia. But my job is almost as cool. So I work 3 weeks out of 4 for a combination of Oxford University and NICE. I chair NICE's Quality Standards Committee and sit on their new drug appraisal committee, the technology appraisal committee. And at Oxford University, I work on quality and safety in remote consultings, and also on the use of robots to deliver medication, which I just think is the coolest thing imaginable. Every 4th week, I'm allowed out to play. So I have a regular contract in Orkney where I work a week of nights and out of hours every 8 weeks. And then the other month I get to choose. So next week I'm off to the Falkland Islands for the first time to deliver general practice care in a really different setting. So I think I have a really cool life, and probably the most enthusiastic GP about their job you'll meet at the moment.
That's very exciting. You've got a wide range of roles and you're doing some cool stuff. So tell us, how did this happen?
Sometimes I pinch myself and wonder exactly the same question. So the long story is when my kids were born, my son had a disability, a mitochondrial disorder, and I'd planned to be an academic GP. But at that stage, and it was a long time ago, 17 years ago, there was only one route locally to get in, and that was to be an academic fellow. And unfortunately, at that time, it was only available full time. So every year for 3 years, I went to talk to the university about whether I could do this role. And every year they say, Rebecca, you're really well qualified, but you've got to do it full time. And the final time I went to talk to them, they said, it's changed. We've got to let you do it part-time, but you'd be setting yourself up to fail. And I suddenly realized that failure wasn't something I wanted to do. And I went off and explored a very different career. So I worked in out of hours. I took up a role as a clinical lead in out of hours, and then a clinical director for one of the health boards for unscheduled care. I moved over from there to work for the Royal College of GPs as their Welsh chair. So lots of policy advocacy, medical leadership. I then went to the Care Quality Commission in England to be their clinical lead for urgent primary care, and at the same time worked clinically for a private online video provider. Do not boo. It was in the early days. Nobody was doing it in the NHS, and it was the only way to get experience in the sector. So that was really good for allowing me to develop really practical skills in video consulting that complemented what I was doing in out of hours. And after 5 years at CQC, it just felt like the right time to move on. And that opportunity that I'd looked for 17 years before opened up with an NIHR In-practice fellowship. So it's designed for experienced GPs to bring them into academia. It allows you to work half-time clinically and half-time in an academic role. So I applied for that and was lucky enough to get it with the awesome Trish Greenhausen team. So I started that in September.
Amazing. So where did this interest for research stem, Rebecca?
I think because I've been on a one-woman mission to change the world ever since I started work, and realised that medicine doesn't work like it should do, like they teach you in medical school. You submit your datixes and sometimes just get labelled a troublemaker and nothing changes. And you try and bring about innovation and run smack into the finance director of the health board who doesn't want to pay anymore. And I think I've tried various different ways to make change. So yeah, I've done it through the regulatory route, working for the Care Quality Commission. And that was amazing, because when you write stuff into an inspection, for example, palliative care patients need to be prioritised by out-of-hours services, suddenly everyone starts doing it. I've tried it through the Royal College, through lobbying and influencing and policy. And for me, research was another way to sort of explore innovation and see what can really make a difference in the health service and to our patients, which is why I'm so excited about my robot project, the Remedy project, because that allows, you know, again, to explore a really practical way of getting drugs to patients during the out-of-hours period. So this is just the latest Rebecca Payne attempt to change the world, and we'll see if this one is any more successful than some of the others.
I love your enthusiasm, Rebecca. So tell us about this Remedy project. How has this been developed, and what are the things that you're trying to achieve with the medication for out of hours? And
yeah, so 10 years ago, the former Chief Medical Officer of Wales, Ruth Hussey, brought a team of Alaskans to Wales to talk about some of the ways they delivered healthcare through something called the NUCA model. And in one of their sessions, they talked about how they supported remote communities, and that was through doing a video consultation and then dispensing medication from a robot machine located in that community. And that had been on my mind ever since, and particularly since the start of the pandemic, whereby we're doing so many more telephone or video calls with patients, particularly out of hours, but actually we're still left with that very real problem of how they get their medication. And it came home to me one snowy night in January in Orkney, where 3 times that night I had to drive down really tricky roads to go and leave medication at the A&E reception for a patient I'd thoroughly assessed over the phone, who didn't need any more medical input, just needed to pick up their medication. And that was the stage at which this thing that had gone around the back of my mind for 10 years suddenly came to the front of it. It's like, enough is enough. Let's do something about it. So I got tweeting to see if there were any products out there that allowed this to happen. And Omnicell, who supply a lot of the UK's pharmacy machines, got in touch to say they had a product that they could develop for this service. And at first I thought, well, let's do it for NHS Orkney. And then I suddenly thought, hey, I'm an academic now. Let's put this into the research space. So I contacted a lady called Professor Christine Bond from Aberdeen University, who's a former head of primary care and a professor of primary care, but also a qualified pharmacist. And she'd done a similar project about a decade before, looking at using machines to deliver pharmacy-only medication in remote communities. Anyway, we started networking. I took it back to Oxford University, persuaded my colleagues that it was a good idea, and then went out to pitch it to everybody I knew. So I spoke at the Welsh Out of Hours Forum, the Scottish National Operations Group, to the Urgent Health UK medical directors, found a couple of pilot sites that were keen to take it forward, and fast forward, 5 months, we've got a viable project, we've had some external funding, and hopefully going live in September after the machines have been modified for the purpose.
Wow, that's really good. So it looks like the project started very well with a lot of stakeholders who are with you. So tell us, how did you manage to persuade people? Because persuasion is a really important skill when you're leading a project like this.
Yeah, absolutely. So I think the most important thing to articulate is what is the problem you're trying to solve, because so many times cool tech comes along and yeah, I've done it myself. There's this cool piece of tech, let's use it in our service, but it hasn't really got a problem it's trying to solve. And so actually we know, particularly in out of hours, with closing pharmacies in the last few months, Boots has announced it's shutting 300 stores, Lloyd's Pharmacy has withdrawn from Sainsbury's. We know there's a real problem, particularly out of hours, with getting medication to patients. And so I think by being able to articulate the problem, and that problem tapping into other people's perception of what the problem is, it's then easy to build a coalition around what the solution is. So I think that's number one for me. The number two is by having good networks, and good networks are about good relationships, and that's about friendships. I'm quite a friendly person. You know, I like people, so yeah, investing in those professional friendships I think is really important, and not just with, you know, people that can help me, but with people across the spectrum, you know, from clinical fellows and junior doctors through to people in really senior roles. Actually building those friendships, investing in those relationships, drinking coffee together, asking about their children, then means that you've got a network to tap into. And then the third thing for me is social media. And I absolutely love Twitter. Twitter, oh, it's brought me jobs, it's brought me friendships. And when I was Royal College chair, it allowed me to get stuff done. Also got me in lots and lots of trouble, but that's another story. Anyway, so by tapping into the power of social media allowed my networks to be amplified, and was super helpful for finding that supplier who was prepared to modify their tech. So they're the three big things for me: being able to articulate the problem, having a network to tap into, and using social media to amplify that network.
Absolutely. So that's really important. So even for GP trainees and GPs, we have to persuade our patients sometimes, and learning how to do it very well is a skill that takes experience, and sometimes people are not really taught well how to do it. So when we look at the skills that you develop as a clinician, tell us how will the development of consulting remotely have developed as remote consultation is becoming more popular?
Yeah, can I tell you one more thing first, though, about that influencing piece? Because I think this applies just as much to our patients as to other people we want to influence. And that's being able to answer the what's in it for me question. So, you know, if I'm persuading somebody they really want a cool robot, you know, what's in it for them? And too often, I think both of our patients, and when we're linking in with other people to get innovation taken forward, we can answer what's in it for us, but maybe, or even what's in it for our patients, but not what's in it for the person we're talking to. So if it's a finance director, it's about efficiency, it's about good use of resource. If it's for the medical director, it's about improving clinical governance and improving safety. And when it's for our patients, I think we really need to listen and understand and tap into their, and I know it's cheesy, their ideas, concerns, expectations, so that when we're pitching the lifestyle change or the drug intervention or whatever it is that we feel they need to do, it's really aligned to their agenda. And I think the other thing I found really helpful in consultations, and also with my teenagers, is going on a coaching course. So I'm a qualified coach, and taking my consultations out of the I'm the doctor, I'm telling you to do the space, and into that coaching, supporting, what do you want to achieve, and how can I and how can medicine take you there space? Again, ideas, concerns, expectations, I found really super helpful.
That's
And now
great.
for the first question you asked me.
So I think you've got a lot of experience in having these communication strategies that would help people to be better communicator. So if you had been given to teach GP trainees to prepare for the MRC GP SCA, what would you make sure that they learn, Rebecca?
So I'm going to put my cards on the table and say I'm so confused by all the changes in education for GP registrars. I have no idea which bit of the exam is which. So if we're talking about the clinical skills bit, which the bit delivered now by video, my number one tip would be actually do video consultations, because I know you're only assessed on the sort of talky bits and not the examination bits. But actually, you know, you can always tell when somebody's done something 100 times as to when they're doing it for the, 10th time, and number 1 to 9 was just practicing with a mate. And I would say, do video consults in lots of areas. If it's Wales, you'll have access to the Attend Anywhere package. If it's Scotland, you can request access to Near Me. If you're in England, lots of ICSs have brought in packages. So see what you can find and integrate it into your normal practice. And yes, it will involve examining people that you don't have to do in the exam, but that is good practice, and it'll just give you this air of expertise that other people won't be able to compete with. I think there's certain things to be aware of in a video call. The first one is lag. So make sure you're not talking over the patient, because even like a microsecond lag can mean that happens. So rather than using all the and all the rest of it you do face to face on the telephone, really accentuate your body language to make that work. And then use all the skills you already have. You know, it's not scary. It's just building on what you do every single day as a GP. So that would be my exam related tips. I've got some more tips about where it's really useful in clinical practice, if you'd like to hear those.
Absolutely. I'm sure people want to know more.
Yeah, so I did a master's in public health in the middle of the pandemic, which was just an amazing opportunity. And for my dissertation, I looked at that question as to where is video consulting helpful? And there were a few areas where it was super helpful. So the first one is in kids. You know, those kids where you're not entirely sure, are they moribund on the sofa or are they actually fine, but mum is anxious? And often by clapping eyes on those kids, you can make much better clinical decisions. So I had a situation when I was out on a wild, windy island. In fact, it was an island chain. And I was speaking to the parents of a child who was about 40 minutes drive away. And the child was ex-prem, at risk of respiratory problems. And, you know, I just didn't have all the information I needed on the phone. And by flipping to a video call, I could see just how sick this kid was and organise an ambulance rather than let the parents drive them to me in out of hours. So getting eyes on the kid, telling if they're sick or not, super helpful. Getting additional trust and rapport, so helpful. Just by being able to see people, we can often develop a deeper level than on a telephone. And I find it really helpful for mental health, because being able to see somebody, you know, what's their surrounding like? Are they well dressed? Are they dressed at all? Again, it gives you that extra layer compared to a telephone consultation. A lot of the video packages we can use will also allow you to bring somebody else into the call, which is super helpful if it's, say, office hours, you've got an elderly person whose family member cares for them a lot but is at work, and you can bring that extra person in and have a three-way conversation. I find that super helpful. And then in the urgent care context, again, as part of initial triage, just like with the kiddies, being able to flip on a camera and see what's going on, super helpful. So they're my top tips for video consulting.
Thank you for sharing these tips. That's really practical. So what are the common pitfalls to be aware with remote consultation, Rebecca?
So there are things that are more challenging safety-wise in the remote consultation, and certain things that should just kind of make your antennae start twitching or alert your spidey sense. So I've recently done a big analysis of patient safety events in relation to remote consults. And what I'm about to say comes from that analysis, which will hopefully be published over the autumn. So the first one is repeat remote consultations with the same patient. That's kind of a real area of risk. Like 1, fine, 2, probably okay. If they're phoning back again about the same problem, it would be sensible to clap eyes on that patient. The next point is related to that, and that's that a lot of error has occurred where a diagnosis has been made remotely and then not treated as a provisional diagnosis, but given the same weighting as a diagnosis face-to-face. And things like skin problems, you can easily go sort of down a rabbit hole treating a skin condition you've only seen on photographs, clap eyes on it, go, oh my goodness, that's something else entirely. But not just skin problems, you know, anything that you've diagnosed remotely, I would suggest you retain as a provisional diagnosis until somebody's been seen face to face. And then certain medical conditions are just inherently high risk. And every out of hours doctor knows this. Most people, when they've gone for their out of hours induction, will have had a clinical director going, be really careful with stuff like abdominal pain, pregnancy, young children, patients who are immunocompromised, breathing difficulties, chest pain, things like that are high risk, and it would be wise to consider seeing face to face. And if you're not sure what should be on that list, just find an out-of-hours doctor, especially an out-of-hours clinical director. They'll have responded to years worth of complaints about it for their service, and they'll tell you. Another problem is with kiddies. It's easy to underestimate the urgency of a situation when consulting remotely, particularly with kiddies, but also other age groups as well. And with kids, there was a theme identified of failure to identify congenital abnormalities remotely. And I think most of us have veered away from seeing very young children remotely. But, if you are still doing that, maybe one remote consultation, but then really just bring them in for a face-to-face. Sometimes there can be issues where chronic problems aren't dealt with properly remotely. And this is really patient specific. So for perhaps a younger person with hypertension, doing telephone calls can be brilliant because they don't need to take time off work. They'll give you their readings. You might get better compliance. But certain things like checking inhaler technique or checking the diabetic foot, it's much, much harder to do remotely. So think about seeing those ones face to face. And getting to the end now, there's just 3 more. Not all practice systems are correctly set up for remote consulting, particularly if the clinician isn't on site. And a couple of examples, if you get your blood test done by ticking a little bit of paper that the patient takes to reception to get their blood test done, and the patient isn't there to take it to reception, how do you get the right things into the patient record? And I've certainly had an issue where I wrote it into the patient record on vision. The receptionist booked the bloods and didn't click on the see more bit and missed half the bloods. So things like that. Just make sure the processes work for remote consulting. The next one is failure to listen to a patient or a relative who says they need to be seen face to face. And, in these days of limited capacity, it's easy to sort of think that we can just do everything remotely. But if somebody says they need to be seen face to face, they may well be right. And even if they're not right, they're still much more likely to complain or to sue if stuff does go wrong. So my suggestion would be, if somebody insists they need to be seen face to face, you might as well use that 10 minutes seeing them face to face rather than arguing with them about whether they need to be seen face to face. And actually, that was the last one. So they're the common safety issues that it's wise to be aware of in remote consulting.
Are you enjoying this video so far? If you want more insight every week, then you might be interested in Fulfill Friday. This is a weekly newsletter in which I share exclusive insights on things I'm thinking and what I'm working. This is what some subscribers of Fulfill Friday have said. Join over 700 subscribers so you don't miss out on exclusive insights every Friday. Click the link down in the description below. It's completely free. That's great. I think it's really important to hone in that, some people will be better seen face to face, and commonly patients find that if they're seeing a doctor face to face, they'll be able to have a better consultation, a proper assessment. And that's one of the causes of complaints a lot of out of hours can get, where patients are not seen. So when you analyze the data, was anything that surprised you, Rebecca?
Oh, interesting one. I think coming from predominantly an out of hours background where our processes are really optimized for remote consulting, I was a bit surprised at the number of examples of practices that had employed remote consulting and still 3 years on from the start of the pandemic hadn't put the processes in place to support that and make sure it worked properly. And I think because it was all done in such a rush at the start of the pandemic, now is a really good time to just check that the processes in place are working, that they're allowing access, that they're allowing referrals, that it's all working as it should. I'm a real systems and processes person, as you might expect from somebody who spent 5 years at CQC. And too often we end up blaming clinicians when the clinicians are doing everything right, but they're sitting within a system that isn't supporting them. I'll give an example from years ago when I was fairly newly qualified. I was locuming at a surgery, asked to do a smear, and they didn't have the right, I want to say scrapey things, because it was before the current way of doing it, for the liquid-based cytology. And I used the stuff for a postmenopausal woman on a premenopausal woman because I couldn't find anything. The nurse wasn't in, I just thought I'd do the best I can. And the sample was obviously inadequate. The patient was really stressed. There was an investigation by Cervical Cytology Wales. And, you know, I should have used the right brush, but actually I was in a system that didn't give me the right brush. And we need to make sure that our clinicians have got those right brushes or scrapey things, you know, the tools to do the job, because otherwise, as clinicians, we get blamed, but actually it's the process that we sit in. Similarly, in out of hours, you know, I've investigated incidents where people have given out of date medication, and often the response is, well, the doctor should have checked the date. But we should never be giving a doctor out-of-date medication to dish out. That's a system problem. And I think most doctors have heard about the Swiss cheese model, where clinical incidents happen because the holes in the Swiss cheese line up. And we need, as practices, as out-of-hours organisations, as health systems, to make sure that our processes will allow clinicians and actually administrative staff to really avoid patient safety errors.
Yeah. So I think what you are saying is a common problem a lot of GPs are experiencing. It is becoming increasingly more difficult to provide safe care, given that a lot of safeguards that exist are not working well. So for example, if we've got patients who are waiting for ambulance for 18 hours, then they might call the out of hours back. And as a GP, there's very limited advice as in what can be done. So how would you say GPs can work better to manage these complex cases?
Well, I think the first thing is reducing double handling. And, you know, we often see this, that a patient will maybe request a face-to-face, be given a telephone appointment, be unhappy with this, go to A&E, say, be turned away and told to go back to their GP, and then pitch up and out of hours. And they have multiple touch points with the system. And as a result of that, actually, it's creating so much extra workload. It makes it really, really difficult. So I think anything we can do to make every contact count will be really super helpful. So, you know, for me in out of hours, obviously can't take on the job of it in hours GP, but, you know, really trying to do a thorough assessment as I can and not bouncing work. And yeah, if we can stop that workload going around the system, I think that will make a big difference. In terms of us working within a system that does not feel safe, I think it's so difficult. And, you know, I've worked in places where you just go home and worry about the patients all night. And it's really inspired a lot of my career trying to, you know, find those things that will make a difference. And I don't have a solution. Running off to islands like I've done to work in nice environments is clearly not an option for everybody. So I think there's stuff at the individual level we can do, which is just the best job we can, where we can influence to create safer systems. You know, just stuff as simple as making sure that there's a mechanism for the people who are really acutely unwell to be recognised and sort of, you know, in an out of hours waiting room where they might be there an hour, pulled to the top of the queue so they're not sitting there deteriorating. Working with the ambulance services, supporting them, advising over the phone to, again, try and reduce that double handling. For me, the biggie is palliative care, making sure in hours those just in case meds are prescribed, making sure that advanced care planning is done so that those patients are as sorted out as they can be in hours, so they're not coming into urgent care services and admission. But I think it's so difficult, and so there's something around that lobbying level, sort of influencing, showing people why primary care is so important and it needs to be properly funded, resourced and supported, because particularly when systems are under pressure, everybody looks at A&Es and hospitals, but actually the work we do in general practice is so key to keeping everything going. And I think also the more support we can get to get good chronic disease management, the better, because actually, you know, when the whole system is under pressure and we're just doing the most urgent things, it's hard then to do the most important things. And so I would really welcome a focus and a resourcing of chronic disease management in primary care. Does that help?
Yeah, I think it's really great to get your perspective on this. And also, There has been a lot of people discussing about the NHS workforce plan. I don't know if I had a chance to look at the report then, because definitely there is an issue with not just recruitment but retention, and a lot of GPs are finding it very demoralizing to carry on working. And portfolio carer seems to be one of the solutions for GP to stay working as a GP, but also keeping things sane for themselves. What has been your experience as a portfolio GP?
So I haven't read the workforce plan. I've thought about it and realised how many pages there are and not. But my husband had an episode of burnout 6 years ago that he's very open about. I'm sure he won't mind me talking about. He's not a GP, he's a hospital consultant. And basically his service was understaffed by 3 consultants, and he tried personally to step into the gap. So he'd spend all day seeing patients at one hospital, and then he'd spend all evening driving around one of the about 8 other hospitals he was looking after, and it almost killed him. It made him diabetic. He developed serious liver function abnormalities. He was super stressed, and I think the learning for me there was that we try so often so hard to step into system failures. So, you know, the system didn't bother recruiting the 3 extra consultants needed, and he tried to fill that gap. And actually, you know, things like poor policy at a national level, inadequate funding, you know, all the things that we see day to day, we can't fix by just doing more and more in our surgeries or our out of hours. You know, anyone on out of hours list will get all those texts going, oh yeah, can you do this shift, can you do that shift, and you know, can you stay on at the end of your shift? And it's really easy to be a hero and try and do that, but the problem is it just allows the gaps to remain plugged only by your blood, sweat, toil and tears, and at the end of the day nothing changes. So my advice would be that we can all do what we can, but we need to recognize what we can't do, recognize the responsibility that sits at system level and escalate that to the right level. So that might be to health board level, that might be to government level, that might be through using social media, that might be through engaging with people like the college and the BMA to talk to the journalists, that might be through you know, trying to win friends and influence people. But what we cannot do is fill all those gaps that are created by bad decisions elsewhere in the system.
Absolutely. So I think in terms of the future for general practice, what are the things that you're optimistic about? Because I know you've done a lot of work in technology, and technology seems to be very promising. So have you got any thoughts as in the future?
Well, I think for out of hours, my robots are going to be amazing, and hopefully, you know, really allow people to get medication in a timely fashion, prevent deterioration, and actually prevent the crazy situation we see in some parts of Wales where GPs are having to go out in the car with the driver long distances just to drop around medication because a patient cannot come up to an hour and a half to pick it up from the out of hours base. So I'm hopeful of that for out of hours. I think the current generation of registrars and newly qualified GPs are just incredible. And I think they've got a real focus on what matters, a real desire to provide high quality care and the skills to do it. And so I'm optimistic about the future from that respect. I'm worried about the impact of an aging population, and I don't think it's been adequately taken into account in planning, and I think we need to think really carefully about that and about what sits within medicine and what sits within wider society. And you know, the thing that drove me into predominantly working in out of hours care was sitting in the valleys seeing chaps in their 50s with dodgy knees who'd worked manual labouring all their lives or in warehouses, who the job centre had sent to me for a sick note. And I knew by giving them a sick note, I was starting a cycle that would lead to, you know, poverty and old age, because this was a stage at which they really were in a good position. Kids had left home and everything to build up savings for their retirement. And yet the system was forcing them into benefits and not offering them the help, the retraining, the support into other work. And so I think we can't fix it all as medicine. We need, a societal commitment to building a fairer society, to addressing stuff like inadequately heated homes, the cost of living crisis, all those social determinants of health, because otherwise we'll run ourselves ragged trying to fix stuff that medicine just can't fix. So for me, if we want to save general practice, we actually need to save society. And that's a very big challenge. But I don't unless that is fixed, I think given the problems we face with an aging population, with all the impact of COVID, long COVID and all the rest, it's hard to be optimistic. But we can build a better world. Let's build a better world instead. Politicians, hope you're listening.
It's important to talk about the challenges and be realistic. And I think you've given us some insights and perspective of where we're seeing advancement in technology and where we need to be looking at managing the long-term conditions and aging population in a different way.
Yeah, absolutely. And our society, we know that how important the first few years of a child's life are, support for young families to make sure every kid gets the best start in life, all the social things that are an investment in the health of our population, but are wrapped up in the sort of other ways, like toddler groups and things like that. Luncheon clubs for older people that stop them being lonely and coming to visit us in general practice instead. There's so much out there that we see in the surgeries because of social issues. And for me, the in isn't just increasing the NHS budget, it's actually tackling those underlying social issues.
Great. So last question before we close. What really drives you, Rebecca? Because I can see there's a lot of energy when you're talking about these issues.
Yeah, well, I guess a number of things. I guess first of all, my faith. I'm a Christian, and I get really irritated by politicians that kind of spout Bible verses and don't live it. The message of Jesus was pretty radical, and his concern for the poor and to create a transformed society actually inspires me now, 2000 years later. I guess the other thing that inspires me is complete frustration with the status quo. It's like, how long has humanity been on the earth? Like, we should have got by now that if people are in cold, damp houses, they get sick. This isn't rocket science. Let's try and fix it. And I think I'm just one of those irrepressible people who doesn't take no for an answer. And and I love what I do. I absolutely love my job. You'll see that on my Twitter feed at OOHGP Wales. I'm so grateful to do stuff that every day I get up and I just feel so lucky. And if I stop feeling that, I go and get another job where I feel that again. So I think I've always been unafraid to say when things aren't working and to explore new challenges. So yeah.
Thank you very much for sharing your insights, and I really appreciated this candid conversation with you, and I've learned a lot. So people can find you on Twitter at OOH Wales, is it?
OOHGP Wales.
OOHGP Wales.
Wales, yeah, which confuses everyone, given that at the moment I predominantly work clinically in Scotland and academically in England, but that's me, OOHGP Wales on Twitter.
Thank you. So thank you very much for watching this episode, and I hope you enjoyed. Let me know down in the comment section what was your takeaway from this conversation. Take care, everybody. Bye-bye.